recording. Okay, sorry about that. Okay, we're back. Short. Get going here. Okay, so we were in the middle of our COBRA discussion. Again, this is just information to have as reference. You don't need to memorize this, but just good to know. You might encounter people who are in the midst of a transition and they need help with dealing with COBRA. These are important things to know about COBRA. That's why we're going over it. It is important to know that it costs quite a bit to use COBRA. Not just 100%, but 102% of what your employer is paying. That 2% is an administrative cost. The idea is that the employer breaks even and the beneficiary gets to stay in the group market risk pool while having continuity of coverage. This is all about continuity of coverage and making sure that just because something happens at work doesn't mean you can't access your health care, especially if you need it. So you can do it, and some people do opt to do it because they are in a plan that all their providers take and they don't want to disrupt coverage. So they can do it. The plan operates the same way, it's just how it's paid for. That's what does not work the same. There was a transition after the ACA for those laid off before May 31st of 2010, which is the height of the Great Recession. The stimulus package gave a 65% premium subsidy for 15 months. So some people had that for a while and then it stopped. That stimulus package, and they might call in asking about that. Entirely possible. Yeah. So if your employer changes plans, that changes for you too. So it's not that you're guaranteed to receive whatever you had before. You're allowed to, if you want to continue receiving what your employer is providing to everyone else who's active, an active employee. So that's the key term, active workers. You can get what they are getting, not what you've got before, for sure. So you have 60 days to elect to choose COBRA. That's either from the end of coverage or from the notice of your COBRA rights, whichever is later. You can decline. And you can go back within the 60 days, but if those 60 days pass and you have opted not to take COBRA, you can't get it on day 61. There's no extension. So it's important to have sort of, done your cost benefit breakdown and figured out what you want to do before 60 days. Ideally before coverage ends, although not everyone gets that chance. Coverage is retroactive with no break. You do have to make a payment. If you don't make it within the 45 days after you've made your decision, they will disenroll you. So it's very similar to other insurance. You have to pay to keep it. And you have independent rights for every qualifying individual. So, yep.
So basically, you can not really pay for coverage, but really have retroactive coverage for like 105 days almost. Or
well, the 45 days are after the election.
If you make it at 60 days, like at the very end, like you can kind of not really pay for insurance for 3 months, but sort of have it.
You could, yeah. However, if you don't make that first payment, they might have the ability to claw it back. I don't know. I have to look at the regulations.
Who says that you're covered during those 60 days? Retroactively, that would suggest that you're not.
You have to elect.
So I mean, you can elect if something happens.
So you could not be paying and not be covered.
Yeah.
And then at the end of the 60 days, if something happened in those 60 days, say I want coverage, and it would go back retroactive, you would still have to make your payment to make it active. Yeah, I guess you could.
So I feel like a lot of people do this. Like when they leave, like when something happens, they don't get anything for 30 days or 90 days or whatever because
Right.
they know there's no real risk.
So, but there is.
You don't continue to have coverage.
But that's because you get hit by a bus, you can say, "Up, I elect."
The
And if you don't
that's-
get hit by a bus, you win.
Yeah, because you didn't pay. It's expensive. This is like hundreds and hundreds of dollars a month.
It's very expensive.
But then
People are
who
shocked.
says you don't pay when you get retroactive coverage? Who says you don't owe money for it?
No, you do owe money.
Yeah.
But that was being made was that you could game it out and not do it. The risk isn't apparent here, but there is a risk, which is the penalty for non-coverage.
Mm-hmm.
And there's also, if you don't want to have COBRA, you want to go into the marketplace, you're outside of open enrollment, you have a 60-day special enrollment period. So if you don't elect within 60 days and you don't enroll into other insurance, it's entirely possible that you won't have insurance and that you'll get penalized.
Got it.
So there is this other cost. It's not discussed on this slide. Just looking at this slide, you could sort of game it that way.
And also, what if there's some rule now as far as insurance that you're not supposed to have like a break-in coverage? Because I know I was in a situation like 10 years ago that I had bought, insurance through my employer, and then, right away I went onto the COBRA, and then when the COBRA ended, this is out of state, and then when the COBRA ended, I then had to elect to buy other insurance privately, and basically, what they say is that you're supposed to keep, I don't know if the correct word is continuity of insurance, but that you shouldn't have a lapse in coverage.
Right.
Because then you could have a problem with insurance.
Yes.
A big problem.
You could, and that was prior to, 2010,
Right.
sounds like.
Right, yeah.
So with the establishment of the marketplace, let me just go over that again, because this is important and something that we see. There's open enrollment, and this is kind of standard practice of insurance companies. If you had it through your employer, you'll know you can only change plans at one point during the year. That's true of the marketplace as well.
Yeah.
The marketplace is open enrollment. This year is November 1 to January 31st. If you fall outside of that period, like if something like this happens or something else happens and you don't have insurance and you need it, you can't get it unless you qualify for a special enrollment period. Losing minimum essential coverage qualifies you for a special enrollment period. A COBRA situation, that qualifies you for a special enrollment period, but you only have 60 days. That is right up against these 60 days. So you're sort of playing with fire if you're, hemming and hawing about whether or not to do this or to maybe get health insurance. 60 days are up, then you can't enroll in the marketplace, and you won't be able to get health insurance. You'll have to pay for it out of pocket, and you'll be penalized for not having insurance. This is all part of the incentive structure of the ACA to get people to enroll in the marketplace. And we'll get into all of that later, but that's an important piece of overlap with COBRA. We'll get into it again. Okay, if you want more, it's out there. There's a lot on COBRA. The important thing is really these timelines. These are just reference pieces for you. These timelines are very, very important when you're talking to someone on the helpline. They might not know. They should have been notified by their employer, but they might not have been. Okay, so we're doing pretty good on the time. Any other questions here? COBRA? Okay. So the marketplace is something that we'll discuss in depth on another day. If you don't have COBRA coverage after you lose insurance, you don't enroll in the marketplace, let's say that's the scenario that we're dealing with, what options do you have? You're uninsured, or you're underinsured, meaning you have some kind of insurance that doesn't cover everything that you need. In New York State, you have a number of options. There's something called the Hospital Financial Assistance Law, HFAL. We'll talk about that. We'll talk about sliding scale clinics and how to find them. Right now, let's talk about who might be uninsured. Number one, largest population, undocumented immigrants. Also in New York City, we tend to have more contact with freelancers or contractors who don't have access to employer-sponsored insurance, students, part-time workers, and people who don't qualify for Medicaid but can't pay for other insurance because it's simply too expensive. These are all the types of people that we encounter who don't have insurance. So HFAL, the Hospital Financial Assistance Law, also known as charity care, $1 billion to hospitals distributed by the state of New York every year. You can access charity care if you're uninsured or you're having a problem with your insurance, it doesn't cover the care you need, you've gone through all the appeals, there's some issue that you're unable to resolve that way. You pay for the service and you meet the income limits, as well as living within the geographic service area. It's important to note that there are no immigration status requirements for charity care. If your income is very low, it's entirely possible that they look at your assets, meaning savings, what you're paying for your rent, things like that. Certain hospitals, but not all of them, can offer financial assistance to people with higher income. HHC options, that is a program run by the public hospital system in New York City. That's the Health and Hospital Corporation. That's the quasi-public entity that administers all the public hospitals in New York City. A lot of people go to Bellevue, Harlem Hospital Center, Lincoln, Jacoby, looking for HHC options. We don't get a lot of callers asking about this because it's a very good program. It's not insurance. It is financial assistance to help pay on a case-by-case, service-by-service basis for care at the hospitals if you don't have insurance and if you qualify for sliding scale. I sort of think of it as being a little bit separate than charity care because it's an established program and it covers most everything. Charity care is really if you're outside of the city or you're in the city and you have some situation where HHC option is not going to work. But it exists. And in certain situations where we've exhausted all the things that we can do for a client and we're at the negotiating debt stage, charity care is also an option, something to keep in mind. These are the requirements of the hospital have to help you with the application. Most hospitals, I'm just thinking off the top of my head, Mount Sinai has a great system set up to comply with this law. They make it very transparent. It's up on their webpage. Other hospitals are not as great about advertising it, but it definitely exists. They do have to help you with the application. You have to make it available in the primary languages in your community. I don't know actually how they determine that. But I have seen it in Spanish. I haven't seen it in Mandarin. I assume it's out there. There's a timeline. They have to respond in a timely manner. There's an appeals process, and you can apply for Medicaid at the same time. In fact, a lot of the hospitals, the public hospitals, employ facilitated enrollers who are like navigators, basically, who help people sign up for insurance. It's in the hospital's interest to help people get access to insurance, but then they're not going to use up their resources paying for that. But they will still dip into charity care in actually quite frequently for people who are not insured. They can't ask for a social. They can't require any tax information, can't deny them based on credit scores, and they cannot forward it to collections while an application is pending. That's pretty key. If we get a caller who says they're getting these collection notices, it's important to find out what it's for, what provider is sending it there, and if that provider is complying with the debt law collections protections. So if someone has a charity care application pending and they're getting something from a collection agency, that's not okay. You can call the collections agency in that case and say, we're about to call the hospital. Could you please put a hold on this while we sort it out? And more often than not, they will do that. Okay, so they can't consider the assets of people over 150% of the federal poverty level. Have you guys discussed FPL? I think it's up ahead. We're on 76. We have about 11 slides to go. Yeah. Let me just discuss that real briefly right now. It will come up. The federal poverty level it's a standard income level that government agencies use to help establish who needs access to services. It's a pretty antiquated idea. It's from the 60s. An accountant working for the federal government came up with this. It basically, 100% of the federal poverty level, which for a household of one is about $11,600. That's the cost of 3 meals a day per year, essentially, not adjusted for inflation or geographic location or anything like that.
And what about rent?
So there's a lot of discussion about rent, transportation, and other costs that are not covered by the FPL, really. So that's why in New York State, Medicaid, for example, it's not 100% of FPL. The ceiling for being eligible for Medicaid is 138% of the federal poverty level. So New York has adjusted upwards and is a little bit more generous with their Medicaid eligibility. FPL, in the case of charity care, 150% or below, they might look at their assets. But they can't if you're over 150%. We have a chart towards the end. It's all over the cubicles. It's readily available online to translate that into dollars, because thinking about it in terms of percentages is not super intuitive. But that is a really key way of approaching financial assistance eligibility. Okay, and they can't ask for information about monthly bills unless they're asking about hardship. Okay? All right. So the charity care applies to hospitals, but not to other providers. Not private doctors, not ambulances, not clinics, not pharmacies, just hospitals. It has to do with typically hospital charges or doctors who are billing under the auspices of a hospital. It's capped at 300% of the FPL, so if you're above that, it's hard to access charity care. There are sliding scale prices at HHC options in the city and at other clinics across the state. Talk about how to find those. You can't work it out for non-emergency charity care type issues. This is a plug here for how to look at policies and FAQs and things like that. That's up on our website. I did a lot of referring back to that section or the equivalent that we had before. It's very helpful to go back and read the actual details of how charity care or something else works when you start to get into giving advice. Don't need to memorize it. It's up there for you to check. Okay, we've been over this. HHC options. not quite charity care, it's more of a sliding scale fee service at the public hospitals. Very good resource there for learning a little bit more about it. The key thing with HHC options, there is a chart on that brochure that breaks out the FPL levels and what your charges would be at various FPL levels. Yeah.
This is just something I never realized. Why is the public?
So, I mean,
it's like, because they're all like, at least nonprofits, right?
some of them I don't.
They are legally, right? Like is this like operated by the city?
So HHC, that's the Health and Hospital Corporation of New York. That's the quasi-public entity.
Yeah.
So they administer the hospitals for the city in the 5 boroughs, not outside of the 5 boroughs, but in the 5 boroughs. So they're funded all by public money, whereas private hospitals have other resources.
Got it. Like Kings is affiliated with SUNY Downstate, right? So is that still like? Okay, I got it.
I mean,
did they really? Okay.
I'm not sure.
There's different affiliations.
This is how that works. Got it.
So like the Columbia University Medical Center, not a public hospital.
Yeah.
Although they do offer, they have a sliding scale system up there as well. Now Sinai, not public. Okay, so that brochure is very good for learning about HHC options. People treat it as insurance. It's not insurance. It is financial assistance. Okay, this is a little bit more about how to find out about hospitals in someone's service area. This health information site, HITE site, is a great resource. All 3 of those links right there are very helpful for finding clinics or facilities where there's a sliding scale fee. Needy Med, that resource is really good, as well as the CHCA NYS website. All of these can be good. You could be on the line with a consumer who says, I don't have insurance. You walk them through eligibility for special enrollment. They don't qualify. There's some issue where they can't get access to insurance right now, but they need health care. You could help them look for a clinic that provides specific service in their area. That's information that you can provide in the helpline. And you can give them these. You can email it to them. You can mail it to them. We do help people with just general questions as well as with specific appeal questions. Totally fine to get into that. Something that comes up a lot with vision, dental, things that are sometimes not covered by all plans. Medicare does not cover dentures, so sometimes you have people who don't qualify for Medicaid, have Medicare, need dentures. We can help them locate dental clinics like at NYU or Columbia, where the students are providing reduced fee services. Okay, so just another resource that's there for you to be aware of. Any questions? All right. An example here. Now we have Maria, single, 32 years old. This is information, by the way, that might not come up when you talk to her, but after you've talked to her for a while, you establish how old she is, how much money she's making, what her taxed household size is, and then what her issue is. Okay, needs to see a psychiatrist, can't afford the antidepressants, wants health insurance, but only if it's affordable. So first question, I think the first question is, what else do we need to know? If this is someone calling and you're speaking to her, what else would you want to ask?
I guess one thing would be to find out if she has a funding income of $222 a week, just to verify that she doesn't have income from anything else or any savings, or she was like, let's just say,
Okay.
give advice somebody, and just to confirm
Right.
that in actuality, that's all she has and nothing else.
So verifying that that really is your only source of income. Let's just go through. Yeah, some people might not be aware that capital gains or rental income doesn't count. You know, that's income.
The fact that she's single doesn't mean never married to me, and it doesn't say it about your household. I'm not sure that that's relevant, but
It is
might
for
be.
for the marketplace. That's based on your tax household. So yeah. So does she claim any dependents? That could be important for.
Then what was she doing before? She might qualify for COBRA.
Okay. All right. And yeah.
How long she's been uninsured for?
Right.
Maybe she just got fired.
And maybe how long has she been receiving unemployment? Because there's a cap on how long you can receive it. Okay. And can we find anything affordable that will meet her needs? We've seen.
Possible that I know a little about antidepressants, and I guess it's possible that you can ask the company to provide them very cheaply.
Yep. That's always
I've
possible.
never known anyone to do that, but they always say.
Yeah, it is.
My mom did that for a long time. Not with antidepressants, but with a host of other
Sure.
medications and for years. And it always came to.
Yeah, they don't get asked very
They don't, you know, and that's a good point, you know, not to lose too much focus on this, but just pivoting away slightly and talking to providers of health products. So sometimes I had a case where I was working with someone who needed a microprocessor knee versus a hydraulic knee, and it turned out that the manufacturer had encountered that specific situation before and was able to provide quite a bit of information, especially in terms of independent research to why that was medically necessary, that was able to help with the appeal. So in the case of medications, yeah, although there might be a couple of other steps that we could try.
A lot of times what I've encountered, even with insurance and everything else, you know, just to see if you could save on the cost of the medication that you take. And I found that you just go online and you just type like a specific like medication name in, and you say like so-and-so medication, and then like either coupons or savings discount, and you do end up saving a lot of money.
Yep, entirely possible. I think the sliding scale clinics or reduced fee pharmacies might be a good resource if we truly can't get her health insurance.
And then she says she needs antidepressants. Maybe she hasn't seen a psychiatrist. And
Right.
She wants to
She
just
says
get the
she needs.
antidepressants.
So,
You've got to
we
nail that down and try to find. And I think you need to find her a psychiatrist before you try to find her insurance, just because that sounds like an emergency.
that could be. Yeah, right. Yeah, if there is an emergency situation, definitely you want to steer someone to the right resource. Absolutely. Assuming that this is someone who is not in an emergency situation, we can talk to a little bit more. I don't know what her citizenship status is, but it's entirely possible that she would qualify for Medicaid based on how she's presenting right now. Her income is quite low. That works out to be, let's say, about $1,000 a month. Assuming she's not, this is stuff we'll get into later, but she's not over 65. She's not certified blind, not certified disabled. Household of one making $1,000 a month, resident of New York State, and otherwise in good standing with immigration services or as a U.S. citizen or a permanent resident. Assuming she meets all those criteria, she could be eligible for Medicaid and could sign up right now, and that would cover her drugs. Those are questions that we haven't talked about Medicaid eligibility yet, but it's entirely possible that she would be eligible for insurance.
Are there like intake forms or
There are. There's a checklist and everything. So, like I said, it's a lot of information. There's no expectation that any of this will be memorized. Okay, that was just an example. If she was insured, we would ask, Maria was insured in that example, is the medication that she needs, is that on the formulary, which is the list of drugs that are covered. You can get formulary exceptions if things aren't covered under a drug plan. You have to request that the plan do that. You have to find out how that happens. That requires some advocacy and working with the patient. It might be that the medication is unaffordable. That's a situation where you might steer someone towards a sliding scale or reducing if you've gone through these other steps. And if this isn't already noted in any paperwork they have, or if they haven't discussed this, can they take a generic? That's always something that the insurance plans prefer because those are cheaper. Some cases, you can't take a generic and have a letter from your physician stating that generic is not going to work. And that's where you can get into the appeal process. So that's if you're insured. If you have Medicare, which is a form of insurance, but let's say that's the kind of insurance that you have, there are these other programs, EPIC, the Elderly Pharmaceutical Insurance, something with a C. That's a plan in New York State that reduces the cost of prescription drugs. You have to be enrolled in Part D, but that's a plan that's out there, or it's a program that's out there to help people with pharmaceutical needs. And the LIS, which is a Medicare-specific subsidy program for drugs. Okay, and then this last case, if Maria was indeed not eligible for Medicaid for some reason or another, right, or couldn't get it otherwise, we have MediMeds or those other clinics. You also have HHC options if she's in the city. Okay. This last little bit, I think, is just about federal poverty level. So let's just make sure that that's what we've got here. Okay. This is the last section, and I guess we can talk after that. So as we discussed, this says that it's a minimum for clothing, transportation, shelter, and other necessities. That's not the case, actually. It's just based on food, but there's a move to expand it. So HHS, they're the ones who establish this. It does change. It is adjusted on a year-to-year basis, and it does vary according to the number of people in your family. We have a chart, which is towards the back. You'll see it, that breaks it down month by month and year by year. We use it a lot. We use it mostly to figure out what people are going to be eligible for in terms of financial assistance on New York State of Health. That includes public health insurance, also known as the largest public insurance program is Medicaid. Every January is when we see the new ones. Okay, let's spend a little bit of time on this chart. This is going to be maybe your number one, maybe your number 2 or 3, I don't know, most useful document. There's this one and the one after it are essentially the same chart. This is broken down by month, and the following chart is by year. To figure out your eligibility for financial assistance on the marketplace, New York State Health, the Department of Health Marketplace uses your family size and your income. And that's how this is broken down. On the left are the number of people in your family, your tax household, and stretching across the x-axis would be your income. So how does this work? 138% of the federal poverty level translates to, for a household of one, $1,342. And I wish I had a pointer, but I don't. Does everyone see where that is in the chart? Yeah, all right, maybe we don't need to do that. All right. So if you're making that or below in a given month, then you're eligible for Medicaid. I'm just going to move to the annual chart. That's 16,105 per year. Make above that, you're not eligible for Medicaid, but you are eligible for some other kind of financial assistance up to 400% of the federal poverty level. In this case, 46,680. So that's generally how to read this, and then you know, as your family size changes, those levels go up, and there are other things to keep in mind. But this is basically how to establish eligibility for different kinds of assistance. Okay, so then we can talk a little bit about that, and there will be, I think, a day where we get into all of what this means. But that middle section between Medicaid and the full premium, where it says advanced premium tax credits and CSR stands for cost sharing reduction. That is a form of financial assistance if you are between 150% and 400% of the federal poverty level. Oh, sorry, 150 and 250%, right, for CSRs. This will be discussed in much greater detail on another day, but this is how you'll see FPL, federal poverty level. You'll see it here. You'll see it in a couple of other situations. HHC uses a very similar chart to Health and Hospitals Corporation for their options program. They also break down your sliding scale fee on a very similar basis. They also stop at 400% of the federal poverty level, above which you're not eligible for any kind of assistance. So this hopefully is, okay, you should not think that you need to know this cold right now, but you should just know that it exists. That's the main idea. This is an introduction. We can discuss it right now. We have a little bit of time. This is our last slide. So, any questions maybe on the annual or monthly chart? Yes.
Maybe we might be talking about this in the future. I think we will be, but it's interesting to me, like there's a 1 to 18 age bracket, and then there's the bracket for under 1 year of age.
Yep.
And for pregnant women. And I'm going to talk about that later.
Yeah, most definitely. It changes depending on your situation. So this is the generic how it works for someone, but it's very different if you're not an adult. If you're under 19, it doesn't matter if you're documented or not, then you qualify for either Medicaid or Child Health Plus, which is it's also public insurance, like Medicaid, different program specifically for children.
Like children alone.
Children alone.
Really, really young child alone. Like for example, like a 5-year-old would know. I'm just trying to picture how that would fit into the scheme of social support. Like,
I mean,
to me to like just write a healthcare policy for a 5-year-old.
Right. Well, it's there to help children get easier access to health insurance. So your parents might not qualify. Maybe they qualify for advanced premium tax credits, but you qualify for some drastically reduced fee for your insurance.
It's kind of like separate policies under the same household.
Could be.
Yep.
That can happen.
Got it.
That's a possibility. Yeah, so that we're looking in the fine print now, and we will discuss that later, but I guess the takeaway would be this chart applies to adults and most people in New York State who fall into this population. I guess I could talk about what this population is. This is called the MAGI population. That's modified adjusted gross income. If you've ever looked at your 1040, your AGI, your adjusted gross income, is line 37. That is your income, your taxable income, minus a few standard deductions. Not itemized deductions, not other deductions, just a couple of very specific ones. Modified adjusted gross income is the accounting methodology that has been adopted under the Affordable Care Act to help calculate your eligibility for financial assistance. It's modified because you're modifying your adjusted. You're adding back in a few things that are not included in your adjusted income. Don't worry, this is broken out later. But this is the MAGI population, and it is anyone who is under 65, not certified blind, not certified disabled, and, well, I guess U.S. citizen doesn't really matter. Citizenship doesn't matter as much. Those are the main exceptions. If you're over 65, something else is going on. That's all you need to know right now. If you're certified blind, certified disabled, then and you're eligible for Medicaid, if something else happens. But this is the majority of people in New York State, the largest population, part of the MAGI population. So, and this is a taste of some of the other things that you'll learn in other trainings. What is MAGI population versus non-MAGI? And how are you going to know when you talk to someone? What are the questions to ask? Get into it later. So that's the basic insurance context. Our goal for the last 2 hours was just to go over, in broad strokes, what's out there and what you're going to be drilling down into the next couple trainings. So we've got time for questions. Anything that's a burning question? Did you say there was a test? A post-test. Okay. A post-test today? All right.
I just have a question.
Yeah.
Is it a scheduling issue?
Yeah, supervisor.
Yes. Hi, did you tell us? Yes. Hi, I'm there. Okay. I won't be able to make the training a week over Tuesday. Yeah, so we usually do it and you know, we like different. So just happening next week, or you reported next week. So we're looking at all in the week and we'll be after the holiday that we can find out. Okay, we can arrange that.
I adjusted myself. Can you find out where the there is?
Sure, for sure. So, any other questions that came up as we were talking about EPOs, HMOs, fully insured, self-insured? What else did we talk about? COBRA. Premiums, co-insurance, co-payments, cost sharing in general, the federal poverty level. Okay. Any questions about CHA? Since I'm a CHA person.
As the phone calls come in, you find that after you've been here a while, the majority of them are very complicated, the majority of them are simple.
What's the breakdown? Simple versus complicated? I would say that, I don't know. I mean, I feel like every call is a little complicated because you never know at the beginning what direction it's going to go. And, you know, even if it goes through 2 or 3 people, it might be the 4th person at CHA who asks a question that wasn't asked before that totally changes the case. So even simple cases could end up being complicated. I would say that there are not that many that are simple, but they definitely come in. Sometimes it's just like, oh, that's an explanation of benefits. It's a breakdown of, you know, your responsibility versus what the plan is paying. That's all it is. And they have no further questions and they're all set. Great. I don't know. Maybe that was like less than 15% of the calls. and other things tend to be more complicated. Is that your experience?
Yeah, I think that it's probably the even split between complicated and like more simple quick cases. I think that as you grow and you develop proficiency, you know, what was one complex will become quick and simple, but over time becomes way more. But I think that there's a difference between cases that can need more case management than those that you can resolve on one call or two. This one with all the people like that is someone all the time and it's not like you have to figure it out.
I feel like most cases end up being complicated just because everything's complicated. So when you start thinking about it, you're like, yeah. But I guess it's true, some of them are pretty quick answers. Other questions? CNN questions versus chalk questions? So there's 7 more days of training, or 6 more days?
6 more days. So Thursday, and then the 3 days, and then the following week.
And you're going to be seeing a bunch of different people come in here, like myself, or case handlers or counselors, and everyone has different perspective and different experience. So I definitely encourage you guys to ask questions. I'm Matt, if you need to ask me anything later on. Anything else? Okay. So maybe I'll stop this.